Okay. I'm Mohammed Rafiq from Mondi Pharma. First of all, I'd like to thank Dr. Ashraf Armia for his effort to put this meeting together, and to thank all our esteemed speakers. I believe the topic today is very interesting, and all our attendees will benefit and enjoy this interesting meeting. So I'd like to encourage them to ask you all the questions they need to know more, and to benefit from this opportunity of such a great meeting. Wish you all good luck. Thank you.
Thank you. Thank you, Mohammed, so much. My guests, I'm really honored today to moderate this Zoom streaming live from Cairo, Egypt. It is a journey of uveitis from front to back, organized by Mondi Pharma Company. My pleasure today to have my dearest, eminent international ophthalmology friends from all over the world. Dr. Harry from UK, Dr. Paul from Canada, Dr. Ahmed Elkarmouty from UK, Dr. Ahmed Shama from Egypt, and Dr. Sengul from Turkey. Nothing can stop us conducting science, even in the era of COVID-19 pandemic and our quarantine at home. Continuous medical education must be continued, even if all the big international ophthalmology meetings have been canceled. We are now live for all ophthalmologists all over the world from Cairo, Egypt. So it's my pleasure now to introduce Dr. Harry from UK. He's going to start our uveitic journey. And without understanding how we are going to deal with the uveitis before any complication, or to decrease the complication that can happen from uveitis, so the surgeon can start working, he's going to give a preview and how we are going to prevent everything. So please, Harry.
Thank you very much. I'm very honored to be invited to speak. I'm standing in for Carlos Fabrizio, who sadly could not be here. And he's a difficult man to stand in for. He's a great speaker, and I hope to do him justice, although they're very big shoes to fill. So I'm going to be talking about the future of uveitis management. I work as a consultant ophthalmologist in Moorfields Eye Hospital, and I'm also in Great Ormond Street Hospital for Children. So I look after adults and children with uveitis, and I manage the surgical complications of that. So I have no disclosures or financial interests in any of the technologies discussed in this lecture. I'm basically just going to cover three things, because there's a lot of people talking about some fascinating parts of uveitis. So I'm going to talk about where we are now, exciting recent innovations, and how would we like the future to look in terms of uveitis care. So where are we now? We have really quite a lot of drugs at the moment. We have corticosteroids, which we use a lot of, and they're our best friend and they're our greatest enemy. We can give them topically, intraocularly, periocularly, and systemically. I have to say that since the POINT trial was published a couple of years ago, which compared intraocular Ozurdex, triamcinolone, and periocular triamcinolone, we rarely use periocular steroids anymore, although they do have a place in some patients. We have synthetic disease-modifying anti-rheumatic drugs, or DMARDs. So we have the traditional ones, which we're used to using, like methotrexate and mycophenolate and tacrolimus and cyclosporin. And then increasingly now we have targeted DMARDs. So the Janus kinase inhibitors are starting to come online. So they've been used a long time in rheumatology, and trials are just starting up now on baricitinib and tofacitinib. And then we have biologic DMARDs. So the anti-TNFs, the anti-IL-6s, the CD20 depleting agents like rituximab and interferon as well, which is used quite a lot in various parts of the world. So what's the ideal treatment pathway for uveitis? It involves rapid diagnosis using a combination of the ocular phenotype, blood tests, radiology, and ocular imaging. You want to get rapid disease control using high-dose corticosteroids, whichever route you feel is most appropriate. So if you think somebody needs intensive topical steroids or intraocular steroids or intensive systemic steroids. And then we want to get rapid introduction of a steroid-sparing agent to minimize steroid side effects and to maintain quiescence. So it really is all about getting rid of steroids the second you achieve quiescence. And what's the problem with this? Well, the problem at the moment is that we have a lot of steroid-related side effects. Of our 17,000 patient cohort in our uveitis clinic, we have a fifth of that is managed by glaucoma as well. Our patients need to attend regularly for blood monitoring or regularly for intraocular injections. And they have to come regularly just to have their eyes checked. So it's a huge burden on the patient. And it's very difficult for me now to think of this in the pre-COVID era, but in the post-COVID era, the regular hospital visits are for us almost an impossibility. We're never going to catch up. And we really have to change how we manage our patients going forwards. So what's happened recently that might change how we work? So recently in the UK, we've got access to Iluvien. In other parts of the world, you've had access to Retisert for a much longer period of time. We never actually had access to Retisert in the UK. So we now have long-acting steroid implants. They're amazing. They mean that lots of patients will move from systemic therapy to intravitreal therapy, but they have a cost. They have a cataract cost and a glaucoma cost and an endophthalmitis risk cost as well. It's also not entirely clear how effective Iluvien will be at managing all the different types of uveitis that we look after. Is it concentrated enough to manage diseases of the choriocapillaris and the choroid? We don't really know yet, but many people think not. Iontophoresis is an amazing technology which has been around for a really long time and is just in its infancy in terms of being used in clinical trials and potentially in clinics. And it effectively gets rid of the needle. So we spend a lot of time in ophthalmology putting needles inside patients' eyes. And I think in the future, we'll look back on that and think that that was quite an astonishing thing that we did. So iontophoresis uses electricity to move medication across the cornea down an electronic gradient into the anterior chamber. And there have been a number of trials done in animal models and now in humans as well, which suggest that you can achieve high therapeutic concentrations of dexamethasone in the anterior chamber, higher than that achieved with topical and intravenous administration. So it's reasonable not to know what the molecular structure is in the top left-hand corner. So that's sirolimus, which has been, I think, not particularly overwhelming in its take-up by the uveitis community. But the intravitreal sirolimus trial, in my mind, was seminal because actually it showed that we can start giving non-steroid-based intraocular therapy. And as I said, I don't think many people use intravitreal sirolimus, but I think in the future, we'll move more and more away from drugs that we're injecting inside the eye that give cataract and high pressure. And sirolimus is going to be one of those at the very beginning of that sort of family of drugs. And the last technology that I'd like to talk to in this section is actually, this is my favorite trial that's going on at the moment, is the Ivensis trial. So this electrophoreses a plasmid containing an anti-TNF gene into the ciliary muscle. And then it creates the ciliary muscle basically then creates endogenous anti-TNF. And the company liked to call it an ophthalmic therapeutic biofactory, which again, I think is a nice line. But again, this could be revolutionary because patients wouldn't be injecting themselves every 2 weeks. They wouldn't have all the potential systemic side effects of the anti-TNF medications. They would potentially just need this done once in theatre or in a clean room and then produce endogenous anti-TNF for the foreseeable future. So, I mean, again, none of this is in clinical practice, but I think it's unbelievably exciting. So where would we like to go? Well, in my book, we want longer lasting intraocular therapy. So we now have an implant that lasts for 3 years, but there's no reason why we couldn't be aiming for implants that last 5 years and 10 years, and potentially embracing refillable technologies, like in the ladder trial our medical retina colleagues are using for anti-VEGFs, where you implant a port inside the eye and then fill that up with steroid on an interim basis or a non-steroidal drug. Moving away from injection-based and systemic therapy, so that's both maintenance and rescue. So instead of patients injecting themselves with anti-TNFs or with anti-IL-6s, moving back towards oral therapy. And the JAK inhibitors are very promising in that regard. And similarly with rescue treatment, many uveitis colleagues rescue patients with intravenous methylprednisolone. And again, as I said at the beginning, it's very difficult to imagine us not in a COVID era, but if you can manage patients outside the hospital setting, then you should do. And our neuro-ophthalmology colleagues have moved away from intravenous methylprednisolone for atypical optic neuritis some time ago, and instead give 1,250 milligrams of oral methylprednisolone for 5 days. And again, that's something that we can look towards changing our practice and keeping patients away from hospitals. And my last point really is about hospital independence, embracing virtual follow-up and self-medications. So OCT technology has transformed how we all work, and it will continue to do so. Using anterior segment OCT as a proxy for anterior chamber cells and measuring vitreous haze using standard OCT will inevitably come. And then we'll be able to be rolled out into community optometrists and actually then allow patients to be able to manage remotely. So all patients could have potentially virtual follow-up and just come in for procedures. So I think the future is extremely bright for uveitis. If you think about 5 years ago, we had very few drugs outside of corticosteroids and the traditional DMARDs. A huge number of drugs have opened up, and drug companies have started trialing their drugs for uveitis. And so I think it's a really exciting time to be practicing. Thank you very much.
Thank you, Harry, so much. It's a very interesting presentation. I have 2 questions. First, when you choose to use the local or the systemic approach for treatment of uveitis, how you choose your patient?
So I would say that, again, it depends, and I'm going to answer this question entirely on a pre-COVID basis because it has really changed how we've been managing patients. But I would say that if patients have unilateral involvement only, you'd be more likely to use local therapy. And if they have bilateral involvement, you'd be more likely to use systemic. If patients have ocular manifestations of systemic disease like Behçet's disease or sarcoidosis, then clearly you're going to want to give them systemic therapy rather than local therapy. A lot of our clinical decisions recently around anti-TNFs have been made based on the visual trials, but we've never really had good trials in uveitis looking at disease subtypes, and particularly with regard to the intermediate uveitis patients who really just have macular edema as their main problem. We've never really been able to break down our clinical trials to give us that answer. And I think increasingly patients who have just macular edema and intermediate or anterior uveitis are more likely to be managed now with local therapy than systemic, but it swings and roundabouts a little bit. The 7-year MUST data changed how we practiced quite a lot. We thought we'd move more towards local, and then that data suggested that actually patients who were given systemic therapy overall did better. So it really does depend, and I think it's on a case-by-case basis to a certain extent.
Great. Another question, does COVID-19 inhibit you from using the anti-TNF therapy?
Nobody knows the answer. So we are cautiously now, and only now, starting people on anti-TNFs again. But at the beginning of the pandemic, we stopped giving people systemic therapy. We followed the British Society of Rheumatology guidance was very clear about what our risk stratification was around the use of oral steroids and DMARDs and other biologics. And so we were very reluctant to start people. I have to say that now there is international data starting to come in, mainly from the drug registry groups, who I think have been fantastic at organizing themselves. So each of the countries who have rheumatology drug registries, very early on in the pandemic, collaborated to create an international drug registry to understand what the risk to our immunosuppressed patients was. And increasingly, it's looking like there is no increased risk for our patients who are on immunosuppression. But I'm very, very cautious about how I deliver that information to patients. And in terms of the official advice that I give patients, it's still in line with our national guidance that we want to reduce prednisolone to below 5 milligrams and that we wouldn't ordinarily be starting any systemic immunosuppression. But in my gut, I wonder actually whether our patients are not at risk or if anything are protected.
Thank you, Harry, so much. We have a lot of questions, but we are going to answer at the end. So we are going to move into our journey, and we started with the glaucoma part of the journey with Paul. He's going to give the idea about how to to manage with glaucoma in a medical and laser options. Paul, thank you so much for being with us. You have your presentation. Go.
Thank you so much, Ashraf, and hello to everyone from sunny Canada. As you could tell, the weather is fantastic. Obviously, when talking about intraocular pressure, it's always a balance between aqueous production and aqueous outflow. And we know that usually in uveitis, very often actually the pressure is low because of the prostaglandins that are secreted, which increase uveoscleral and maybe trabecular outflow. And also the ciliary body has some inflammation and maybe does not produce as much aqueous humor. The overall prevalence of glaucoma in eyes with uveitis varies between 10 to 20%, but in chronic uveitis is actually more common and creates a lot of morbidity. The reasons that people have are myriad, and you can have an open angle or what appears to be an open angle, and the trabecular meshwork is full of different proteins, pigments, debris, inflammatory cells, and that's why I have the image of molochia, my favorite Egyptian soup, here on the top right. So imagine you have molochia as your kind of aqueous humor. So it's obviously going to get clogged from all that delicious garlic and everything going through the trabecular meshwork. But also sometimes the angle appears open and the cytokines that are secreted actually cause neovascularizations, those fine little vessels that grow in the angle. It can actually cause fibrovascular membranes, and one can develop synechiae in the angle as well. So actually secondary angle closure glaucoma is quite common in uveitis, and often one has to do iridotomies, and the iridotomies or iridectomies are often more challenging than in usual cases. They have to be made larger because of the inflammatory material. It can often occlude the iridotomy and the patient can go back into iris bombay as well. Other types of glaucoma cause more broad and smaller based peripheral synechiae. So chronic angle closure is actually common as well. And sometimes, for instance, in VKH, more common, for instance, in Turkey and other countries, one can develop effusions, which will cause a rotation of the ciliary body and can also cause angle closure. Another mechanism is a steroid response. Here's a patient treated by his family physician for episcleritis. So these are his 10-2 visual fields. And for 9 months, he was treated with steroids. So he has end-stage glaucoma, probably induced by the use of steroids. Now, who can develop a steroid response? Who gets high pressure due to steroids? It's very well known that patients with primary open-angle glaucoma, patients with family history of glaucoma, especially myopic patients. I find the worst patients are the pigmentary glaucoma patients. They get the most and most rapid steroid response. But one has to be aware that steroid response is quite common. And obviously, it depends on the dose, the chemical structure that we use, the frequency, and route of delivery of the patients. What do the steroids do? It's actually at the level of the trabecular meshwork. We know that it increases extracellular matrix. It decreases the breakdown of extracellular matrix. And it also acts on actin cross-linking and cell adhesion as well. The time of steroid response varies. It can be as early as 2 weeks after starting the steroids. And what's the problem mainly in management of chronic uveitis is it the uveitis causing trabecular outflow issues, or is it the steroids, or is it both? And often we're kind of caught between a balancing act between treating the intraocular inflammation and treating the intraocular pressure as well. So depending on the steroid that's used, obviously we have low dose steroids, and our goal in general, as Harry mentioned, was perhaps to wean off either systemic steroids or steroids which can cause other side effects, maybe use immunosuppressants. For instance, what we try to do in our glaucoma and uveitis practice is, if the patient is well controlled with Pred Forte or prednisolone and we go down to Pred Mild, perhaps we can even switch them to Loteprednol, something in general patients known to have steroid response with the ester type of steroids have less pressure rise. Obviously, steroid injections are also very useful for many of our uveitic patients. And depending in what we inject for our patients, for instance, we can inject triamcinolone, we can inject dexamethasone, Retisert, as was mentioned. You know, pretty much if you injected Retisert, you had 3 out of 4 chance that your patient needed a trabeculectomy over time. And when we follow those patients over time, we know that the peak pressure rise is usually at day number 60. So if your patient has a pressure rise and you're about to give up and you're treating with everything, you should be encouraged knowing that in general, after day 60, after an injection, the pressure does tend to come down. And often those injections are quite beneficial for visual acuity and macular edema as well. So let's talk about a few pearls of glaucoma. I think number one is to make sure that you diagnose the underlying cause. And in general, if you have a high pressure in glaucoma, it's either something that causes granulomatous inflammation, such as syphilis, sarcoid, TB, or toxo. It can also be herpetic. And then it can also be something called Posner-Schlossman syndrome, Fuchs, or JRA. So one should, on initial presentation in granulomatous uveitis and high pressure, do a little systemic workup. And you see that chest x-rays and other blood tests are indicated. With herpetic uveitis, I find this is one of the ones that sometimes can be the toughest to treat, where I got burned initially as a young glaucoma surgeon, but that was 20 years ago, was that often the pressure is very, very high. But remember, you can see in the top right, on the right-hand column, that it does cause sectoral iris atrophy. It can also cause ciliary body atrophy as well. And if you're planning to do a glaucoma filtration procedure on one of your uveitic herpetic glaucoma patients, be very wary. The top left photo is one of my patients who developed hypotony maculopathy. So they really are very close on the border between having extremely high pressures and then they fall into hypotony. And antivirals and steroid medications are very useful in this disease. Fuchs heterochromic iridocyclitis is often missed in general. I just saw a gentleman recently who's been seen by several ophthalmologists, and often the heterochromia is quite subtle. Fuchs actually does not respond that well to the use of steroids. We do use steroids sometimes. They do develop cataracts, and it's important to treat the inflammation around the time of cataract surgery. However, medical treatment is often not sufficient enough, and these patients often have to go on to either filtration procedures or tube shunt surgery. So very discreet, stellate little KPs. Posner-Schlossman syndrome, on the other hand, which is, as opposed to FHI, which was more rubella related, is perhaps more CMV related, responds extremely or exquisitely well to the use of steroids. So use steroids and cycloplegia, add some medications, and their pressure often falls down. However, if a patient has recurrent episodes of Posner-Schlossman, they also may need a glaucoma filtration procedure or chronic use of medications over time. I think that one following for glaucoma should always perform gonioscopy, and there's subtle signs. One can look for, on the bottom left here, Grant syndrome, so trabecular precipitates. Bottom right here, we see fine neovessels growing. So when you do a paracentesis, they'll get a spontaneous hyphema, Amsler's sign, as it's known, and obviously increased pigmentation. I think that often the masquerade syndromes are missed in glaucoma. This patient was presented to us and had high pressure. He was a myopic patient. Look at his nerve. The nerve actually looks great. And this is his visual field. He has visual field deficits. So we go ahead and he has unilateral high pressure OCT. The OCT macula looks good, but notice in the bottom left in the periphery, he actually has a retinal detachment. So this is Schwartz-Matsuo syndrome, also known as, so the photoreceptors from the retinal detachment are floating. They look like they're inflammatory cells and they clog the trabecular meshwork. So always be wary in your myopic patients. It may be Schwartz-Matsuo syndrome. Another syndrome here is Bates syndrome, so bilateral acute iris transillumination syndrome. Often patients taking certain oral antibiotics lose all the pigment in their iris very suddenly, present with cells, but it's actually pigment floating, and they have extremely high pressures. Also, UGH syndrome, so UG syndrome, is often missed. If you have someone presenting with a uveitic high pressure uveitis, make sure to look for transillumination. These patients often have monofocal acrylic lenses in the sulcus, or an optic which is in the sulcus, and the haptic which is rubbing against the iris, as you can tell by transillumination here. This is a patient that had such an issue. On the right-hand side, you see that by anterior segment OCT, there's an absence of the iris pigment epithelium here. And what you can do is perform iris peripheral iridotomy. This flattens the contour of the iris and it stops the UGH syndrome in many of the different cases. Another pearl is that it's okay to use prostaglandin analogs in anterior and intermediate uveitis. Many studies have shown that it can actually be quite beneficial. However, if the patient has had complicated IOL surgery or has posterior uveitis, we tend not to use prostaglandin analogs. Also, some people are very cautious. They say, oh, I'll use steroid drops 2 times a day. If you have trabeculitis, you really have to hit hard with the steroids, especially if you're going or planning to do surgery. So don't be very wimpy on the use of steroids. If their pressure is high and it stays high, then at least you know that steroids aren't the answer. And some people don't prescribe enough steroids or taper their steroids too quickly. Also remember that you can use an anterior chamber tap to quickly decrease a patient's intraocular pressure. And why that may be important, we know here that look at the patient's trabecular meshwork in photo B and compare it to photo A. As your pressure goes up, your trabecular meshwork actually herniates into the collector system channel and can stay blocked. So you really have to acutely decrease a patient's IOP and break these adhesions that form between the TM and the collector channels of your system. And that's why we've had excellent results performing canaloplasty, especially in our younger patients with uveitis. Here's an example with no bleb, no filtration, but Schlemm's canal is nicely open after canaloplasty. The other thing to be very wary of are tube erosions, and maybe Ahmed will touch on this. I just wanted to say that of my patients that develop tube erosions, mostly they are uveitic patients that had tubes. This patient had to have fascia lata. We did this with our oculoplastics colleagues. We used amniotic membrane, and she did not re-erode. She had had 3 previous erosions. And here's a patient I actually saw today. We used cornea. She also has JRA, and 10 years later developed a tube erosion. So make sure that when you have someone with uveitis and you've put in a tube, make sure that the tube is straight, it doesn't have any kinks. Avoid the use of non-steroidal anti-inflammatories, and try to make sure and monitor the ocular surface. Treat ocular dryness, but the chronic use of steroids can also thin the ocular surface as well. As a final point, I think that it's not indicated to do cyclodestructive procedures in our patients with uveitis and glaucoma. Often it can cause an intractable uveitis, which is not responsive to other forms of therapy. So I think if we're planning to go forward with surgery, we're happy to hear Ahmed's point of view on this, but I think that one should consider tubes when there's acute inflammation, and in some cases, angle surgery is indicated as well. Thank you.
Thank you, Paul, so much. It's a wonderful presentation, really wonderful presentation. You covered everything perfect. Thank you. I have 3 questions. The first question, can you stop sharing, please, Ahmed? Yes, please. The first question, when in steroid responding glaucoma, do you see when you use systemic steroids the same reaction with the local or no?
I would say, maybe 80% less. Systemic steroids often do not cause pressure rise. However, we have seen patients that are using corticosteroids for, let's say, systemic sarcoidosis or other issues, and their intraocular pressure goes out the roof. So I think some patients are quite susceptible even to systemic steroids. But I would say in general, the further you are away from the eye, the less responsive they are.
Okay, and in cases of uveitic glaucoma, diagnosed as uveitic glaucoma, what your sharp point when you choose between medical and surgical?
Most often we will use medical therapy. We know that some patients, such as Ahmed may say, in juvenile rheumatoid arthritis, they do very well with angle surgery. So we tend not to, belate the point very often. And in JRA, they do very well with opening the trabecular meshwork. In other cases, patients, if they're tolerating a beta blocker, they don't have asthma or other lung conditions, we can treat them. So it's always a question of balancing IOP, comfort, side effects. But if one is considering more invasive glaucoma surgery, certainly we're less likely to move forward if they're doing well with medical control.
Did you notice any cases of glaucoma related to COVID-19?
So far in my personal practice, even though our hospital is a COVID-19 center, we have not noticed. We do know that intraocular inflammation has been described, but we have not seen those cases. What I do know, however, is that the physician, Dr. Lee, who first noted the presence of COVID and unfortunately passed away seeing an asymptomatic glaucoma patient. So for everyone watching, protect yourselves, protect your patients, and protect your staff.
Okay. The last question, in surgery, did you use always anti-metabolites in case of uveitic cases?
Usually we're quite lenient in the use of anti-metabolites. As a standard of care, we use mitomycin C for almost all of our patients. If a patient is extremely myopic, has poor tissue quality, and we're concerned about melting of tissue, which actually is more predominant in patients with inflammatory conditions of the anterior segment. If a patient has scleritis or other signs of very anterior type uveitis, in those cases, we definitely would not use antimetabolites.
Another short question. How especially you diagnose herpetic iridocystite?
Usually, well, we either ask for a history of labial herpes. The patients have often sectoral iris atrophy, small mutton fat KPs. As some uveitis specialists have said, if everything else comes back negative, treat it as if it is herpetic uveitis until proven contrary. And again, if the patient has good renal function, initially we will be using antiviral medications liberally until another possible diagnosis comes forward. But usually it's a combination of those that we just mentioned.
Thank you, Paul. We have a lot of questions, but I'm choosing some questions. Now we are going to move from medical to surgical glaucoma with Dr. Ahmed Elkarmouty from UK. So please, Ahmed, thank you for being with us.
Ahmed, you just have to unmute yourself.
Okay, yes. Now,
See,
Ahmed,
thank you.
Ahmed, wait, please. I'm going to unmute you. Ahmed, can you unmute?
Can you hear me now?
Yes, yes.
Okay. Can you see the slide? Is it shared?
Yes, yes, clear.
Okay, I would like to thank you, Ashraf, and I would like to thank Mundi Pharma for organizing this webinar, and I would like as well to thank all the panelists for this. I'm sure it's going to be a good scientific event. So I'm going to talk about the surgical point of view for management of uveitic glaucoma. I don't have any financial disclosure concerning any of the devices that I will mention. Okay. Can you? It's not there yet. Sorry. Okay, so uveitic glaucoma in general is a later irreversible complication of chronic anterior uveitis due to compromised outflow and high aqueous protein content. There is a definition of hypertensive uveitis, and this is high pressure, but there is no structural functional damage of the nerve. So the visual field was still full, and the OCT will still be normal. Goldman's equation, we all know it, and I just want to go through it quickly because there is a good classification came from Shenglim about the aqueous dynamics or fluid dynamics in according to uveitis status. So usually, and I will concentrate on the inflow or the aqueous, in uveitis status, if it is acute inflammation, his classification is acute inflammation or previous mild to moderate uveitis have less than 5 attacks, and the third one is the previous severe multiple uveitis that had more than 5 attacks. The thing is, when we treat the uveitis, we treat it as a general uveitic glaucoma, as a general uveitic glaucoma. We have to ask ourselves which kind of uveitis status that this uveitic glaucoma patient have. So in acute inflammation, there is 100% reduction in uveoscleral outflow, but there is as well 50% reduction in aqueous production. So in the previous mild to moderate uveitis, the aqueous inflow and the outflow through uveoscleral pathway is more or less the same, is not affected. But a severe uveitis, multiple severe uveitis, there is a very, very low aqueous production due to inflammatory damage and abnormal vasculature as well. So when we try to treat these different kinds surgically, we have to be very careful. As Paul mentioned, we have to control the uveitis no matter what, even if we have to hammer the eye with intensive steroids and the pressure, and then we can deal with the pressure. But don't go soft on the uveitis by weak steroid just because you are worried about the spike of the high pressure. As a point of view, when we try to treat the uveitic glaucoma surgically, we have to be careful because this uveitic eye can have a 6 ciliary body, and the pressure can go really low over the years. So when we are trying to get very low pressure, like in POAG 10 or 9, this is going to be very, very dangerous to the eye. So when we try to get the pressure lower, please don't try to aim really low. Drainage implant has been the surgical procedure of choice in uveitic glaucoma. There are loads of evidence there on the internet, and as well, it didn't matter much about, or didn't talk much or comparison about the Ahmed versus Barvel in the uveitic glaucoma, but they all have proven that they are very good in lowering the pressure and reducing the number of glaucoma medication. The question comes is which tube to put, which shunt to put. If we go back to the classification of acute versus severe uveitis, we can use the valve, which is Ahmed valve is most commonly used all over the world, or the Barvel tube 250 to use it in VKH or GIA. That's the multiple severe uveitis, because the eye is really sick and do not produce much of a fluid. But if there is non-specific anterior uveitis or glaucomatocyclitic crisis, or Posner-Schlossman, or infectious uveitis, probably we go for the big one, which is the 350. Mitomycin or not, Paul has beautifully touched down on this. But if you are worried about very low pressure or hypotony, you wouldn't use mitomycin. So if I think this eye probably will go low and I will choose 250, then I wouldn't use mitomycin. If I think that this anterior uveitis or infectious uveitis and I need really low pressure for long term, I decided to use 350, then I will definitely go for the mitomycin. The other precaution to do is to, if I'm going to stent in non-valve shunt, I would take out the stent later than I usually do. So instead of taking out at 3 months point, I will take it out at 6 month mark. And as well, I will take it out on 2 stage rather than all the way out in one go. Trabeculectomy still is an option, can be used in uveitic glaucoma, and especially, but less than in Fuchs, because has been loads and loads of cases done by Keith Barton and evidence that in Fuchs it doesn't work for long term. But you have to be careful with the trabeculectomy because you are walking on a very fine line. Trabeculectomy can fail in uveitic glaucoma, has a fair chance of failure due to scarring, inflammation. Patient will need cataract operation and conjunctival inflammation. But on the other hand, there is a high chance of failure due to low pressure, because this is usually youngster patients with sick ciliary body. Be prepared that you will need steroids before and after the operation for a long time. But as a surgical point of view, the precaution would be try to make the fashion your flap thicker than average, a bit thickish. Use extra stitch for the scleral flap. So if you are used to put 2, please put 3. And if you are used to put 3, please put 4. Again, try not to remove them as early. No, try to leave it a bit late. So if you are used to take them out at first week, leave it to second or third week. There are some procedure that has modest IOP reduction, like deep sclerectomy. In these cases, in uveitic glaucoma, or hypertensive uveitis, when only your problem is pressure of 50 or 60, and you would be happy if the pressure go down to 20 or 25 and then add a drop to bring it down to high teens. You can use the deep sclerectomy, but be prepared because it has known and has a reputation that it doesn't work for a long time. Be prepared that she will need another procedure. Express shunt, although it doesn't have very good reputation at all, but in very, very small ratio of patients that have very sick eyes like Behçet or GIA, as I mentioned, probably there is a window to use them. MIGS. There is a role for MIGS these cases, but not all the MIGS. MIGS without the bleb unlikely will do much, like iStent or Hydrus, or the one to the right here, like SAS. I don't think there is any role for those patients. But I think if we have like MIGS with the bleb, I think there will be much better to use Zen or Infocus there, because they have a bleb. The Zen has lower control of pressure because this is a finer or thinner lumen, and the conjunctival inflammation can kill it easily. Paul mentioned the canaloplasty. Angle surgery, I just want to touch down on this because he mentioned that. Angle surgery, the only enemy for angle surgery is that they can scar again, so any cuts in the angle like a GAT or canaloplasty, they can really scar down. And this is inflamed eye. They can easily scar down and close again. So I wouldn't recommend it for uveitic glaucoma. But if you have good results with the juvenile, and juvenile actually have good results with the GAT for POAG, but if it works for the uveitic glaucoma in your hands, so that's it, go ahead for it. You actually as well down on the using of the laser photocoagulation. Again, as I said, not every uveitic glaucoma we can standardize the surgical procedures. So yes, cyclophotocoagulation is probably considered absolute contraindication like serial body VKH, GIA, and Behçet, but in recurrent anterior uveitis or infectious uveitis, the eye is not that sick, especially in the start of the disease. And there is as well a micropulse that is not that pro-inflammatory, like the diode. But again, I agree, these are eyes that have low threshold to develop inflammation. So please be careful when we use this. SLT or ALT doesn't have in these cases. When it's combined with cataract, definitely if the eye has uveitic glaucoma and dense cataract, please try to sort out the pressure first, because if the phaco is can cause inflammation and you will need intensive steroids, then there will be steroid responder with these eyes, spike of high pressure, then you will take him back to theater to sort it out. So please do glaucoma surgery first and don't do combined. So, and leave the cataract for later. Paul as well have mentioned the UG syndrome, and you need really to be careful with the post-cataract inflammation and spike of high pressure, because you have to have a good, careful look out for residual lens matter. And if it is behind the iris and it's very small or medium, you wouldn't detect it. So you need a good UBM technician. And if the eye, as he mentioned, the haptic IOL is malpositioned, don't go for, in these cases, for glaucoma surgery. Just sort out the problem and the inflammation, and you will hit two birds with one stone. You would sort out the inflammation and the pressure. Last thing, pupillary block, as Paul mentioned, probably you should go for surgical iridectomy and posterior synovitis, because there are partitions and adhesions between the iris and the lens in different areas. So if you go for laser PI, this is a pro-inflammatory condition. The iris is against the back of the cornea, thick iris, and you will need high energy. This is not easy. And you need the big, ugly PI, not the small, cutie PI, no. So you have to go ahead with a surgical PI, because if you did the laser, you can go with the laser room with a pressure of 30 or 40, and if it didn't work, you will end up with a patient pressure of 60 or 70, and you will still need to rush him to do the PI. The other thing is, can we do prophylactic PI? So if you have a patient developing posterior synechia and the 300 degrees of adhesion and still have a small window and didn't develop Bombay, you have to discuss with the patient prophylactic surgical PI, because this can help him to avoid a hot eye and wait until he developed the Bombay. So this is just evidence. Patient who had the doctor offered him laser PI, didn't work, second PI didn't work, and the third PI didn't work. So he didn't get the message that he has to go ahead with surgical PI. And this again, at the end, patient needed surgical PI. So surgical intervention depends on status of the uveitis. Not just all uveitis or uveitic glaucoma can be dealt with or treated as the same, tube or trap. No, you have to think, what is the status of the uveitis? Surgical management of uveitic glaucoma is really changing, because it's really unpredictable and the eye behaves very differently from POG and others. Young patients have high risk of hypotony. Iris Bombay, you have to go for surgical iridectomy, and laser PI, I think it's just a waste of time. For the long-term proper control of eye pressure, I think the shunt is preferred, because there is multiple procedure this eye may have from front to back. So I think a shunt will be the best option. So if in doubt, put a shunt. Thank you very much for your attention.
Thank you, Ahmed, so much. Excellent presentation. Thank you so much. Really appreciate it. You have a question from the audience.
Sure. Yeah.
How about iridex, and it's contraindicated or no?
Iridex, the micropulse. Okay,
Yes.
the micropulse is a part of the cyclophotocoagulation. So if you said diode, I would say no for the VKH, GIA, and Behçet or cyclodoses. But if you are telling me this is an eye with non-specific anterior uveitis or infectious, that eye pressure control is out of hand, you can use it. So you always, when you offer procedure, better to tell me what kind of uveitis status is the patient, because not all uveitic glaucoma are the same. So we have to always think what is the reason or the cause of uveitis.
Okay, as you mentioned, if you have a significant cataract with a glaucoma, you said you start with the glaucoma operation.
Yes.
The audience asking what type of operation you are going to choose in these cases.
Okay, again, according to the uveitis, so probably I will go for a tube, that's for sure, because if it is dense and the patient will need it in 6 months' time, I will go for a tube, because this is another operation, and again, pro-inflammatory can kill my trab. So as a general rule, I will go for a shunt. But if this is, I would say, youngster patient, and the cataract is not that dense and it's very early, you're not planning to do cataract in very early cataract in youngster patient, so I would go for trab, because you can still, because of the life expectancy, they may need another procedure. Then I don't want to burn the tube from the first choice. So it depends which kind of patient and the age as well.
If there is a chance of allergen in subscale trabeculectomy or viscocyclosis?
Okay, I don't have experience with the allergen, and I don't think the studies, I mean, I don't want to say studies, but I mean, there is no like randomized control trial of comparing the allergen to mitomycin. So I wouldn't, and showed very good results. So I personally wouldn't recommend allergen.
Okay. If you want to use a drainage implant, is your drainage implant closing different, depends on uveitic etiology?
Yes. So as I mentioned, GIA, VKH, where I would go for Ahmed valve, which is not my preference, but this is one of the very few indications to use Ahmed valve superior to Barville tube in these very sick eyes. So I can use the Ahmed valve or the 250 no mitomycin, because these sick eyes will go hypotony easily if we use the big plate. But other kind of uveitis, like as I mentioned, anterior specific or anterior idiopathic anterior uveitis, infectious uveitis, sarcoidosis, you can go for big tube and use mitomycin as well. All of them will need to be stented.
Thank you, Ahmed, so much. So we are
Pleasure.
going to, you have a question, but there is a question between you and Sengul also, some questions. So I'm not asking this question until she finished, because it is going to be answered between you and her. So we are going to start the cataract journey. I am going to start the part 1, and Dr. Ahmed Shama is going to start part 2. So I'm going to share my presentation. Cataract in uveitis is so different than any cataract surgeon feel it during decision or during surgical procedure. Cataract formation is especially common complication resulting from uveitis. It's a rare. It is rare in posterior uveitis. It occurs 50% of patients with anterior and intermediate uveitis, nearly 80% of patients with Fox heterochromic, as everyone said. Cataract formations usually either posterior synechiae are often seen in focal areas of the anterior capsule necrosis or and underlying lens opacity, fiber membranes over the lens, which is often accompanied by an opacification. There is a theory for the cataract formation. It's a inflammatory stimuli or degeneration might induce proliferation of the lens epithelium. These abnormal cells produce extracellular basal membrane material and extracellular matrix before they degenerate in combination with the surrounding lens fibers. There is two titles very important in cataract with uveitis. First is the uveal biocompatibility, which is the breakdown of the blood aqueous barrier, is the first striking event during or directly after the surgery. To reestablish this blood aqueous barrier, it needs at least 3 months. The increase in the cells and the cytokines in the anterior chamber influences the degree of uveal and also of the capsular biocompatibility. It also, in some degrees, the foreign body reaction occurs in all eyes after cataract surgery in order to clear the debris from the IOL surface. The aqueous humor in the uveitic patients after cataract surgery show abundance of macrophages. You must know this before you touch your cataract patient. Another title is a capsular biocompatibility, characterized by the lens epithelial migration by the anterior capsular opacification or the posterior capsular opacification. There is a fibronectin, which is responsible for the IOL attachment to the capsule, the posterior capsule, and the bioactive bond between the lens and the capsule. I'm going to choose 4 types of uveitis, which is commonly seen during my practice, which is the Fuchs uveitis syndrome, the juvenile idiopathic arthritis-associated uveitis, the Bishop disease, and the Fuchs-Kanagi-Harada syndrome. In Fuchs, the average incidence of cataract is around 50%. Eyes with Fuchs have better visual prognosis. The good vision is attributed to the low-grade inflammation that predominantly affects the anterior segment. But glaucoma is the visually significant complications, which occurs in 3 to 35%. In juvenile idiopathic arthritis, which is it is the most aggressive type I see in my practice, the cataract extraction only is associated with more severe complication and persistent intraocular inflammation. Very important to know that implantation of a posterior chamber IOL at the time of cataract surgery in these cases result in posterior synechiae. Usually in these cases after surgery, we see the pupil distortion, IOL displacement, occlusive pupillae that may cause malignant glaucoma and pupillar block. Usually, glaucoma occurs in these patients about 25%. But some eyes have hypotony in these cases due to the attraction of the ciliary body and it's a process by cyclic membrane. In Bishop disease, which is one of the cases I'm going to present in video, cataract occurs in 17 to 36%. It has a severe worst visual prognosis because the severe posterior segment complication, either optic atrophy or inflammation, as Dr. Sengul are going to say. But the most important in these cases, the posterior capsular opacification, which we're going to see in the video, occurs in 37.5% of the cases. In Vogde-Kayanagi, cataract is most common also, and the cystoid macular edema is uncommon, but there is a problem in the posterior segments, the subretinal gliosis and optic atrophy, which is common. Very important in these cases, before you start with the surgery, counseling the patient, because this is not the normal cataract you are doing in your practice regularly. So you must manage the patient expectation. You must tell him the general risk of cataract surgery and the post-operative inflammation and the recovery can take a lot. There is an indication for cataract surgery. Not all the cataract with uveitis are going to go for surgery. Either it's a poor vision, or to remove the cataract to see the posterior segment in vitreous macular edema or amblyopia. Very important. It's very important also to see the posterior segment. Either it has a new vascularization, CNV, or retinal detachment. Also, if you are going to do a vitreous or macular surgery, you should remove the cataract. Or in rare cases of phacogenetic uveitis. When you are going to say, no, I'm not going to remove the cataract, it's absolute if you have an active inflammation of the anterior chamber. It's a contraindicated. Or if the patient is young patient with a still good, relatively good vision, and the cataract is not dense, don't remove it to reserve the accommodation. The time of surgery, very important to choose the time. As most authorities agree that complete quiescence of the inflammation, it means 10 cells or less in the slit lamp high power fields in the anterior chamber, 8 weeks of remission of the inflammation before the surgery, and never go for surgery if you have a low intraocular pressure, because hypotony will exceed the inflammation post-operatively, or there is cells in the vitreous, or there is a thickening of the choroid. And preoperative anti-inflammatory medication, very important. There is some rules you should take care during the cataract surgery. This is not the usual cataract, as I said. So general anesthesia may be chosen in these in children or other surgically challenging condition because there is a long time of surgery. Phacoemulsification with implantation in the bag is mandatory. It's not recommended to put in the sulcus. Small incision, not a large incision. Very important to have an intact, well-centered capsular rexus overlying the opt edge. Never to do with small rexus, never large rexus. Small rexus is going to have a phimosis and pupillary block because adhesion is going to happen between the iris and the anterior lens capsule, the edge of the rexus. If large, very easy to have a displaced IOL. Choosing the IOL material and design, very important, because you should choose to reduce the PCO and post-operative inflammation. So hydrophobic acrylic, very important, or a female IOL. Also, the sharp design of the IOL can delay the PCO, which is common in post-operative cases. The most common, I'm going to stress hyphema, which is very common to happen in these cases due to the adhesion of the posterior synechiae and the inflammation before the operation. So if it happens, it's very easy to inject the high visco OVD, wait till and increase the pressure by injecting more, wait till the hyphema stops, then continue your operation. Never wash, because washing of the hyphema, we're going to increase the hyphema. The first case I'm going to present it's a seclusive pupillae. So usually I go with the NPR, with the parasynesthesis, just to open a small plane under the iris. Then with a viscodispersive OVD, I usually try to inflate the anterior chamber, and with a microrexus forceps, trying to remove the membranes, which is very important in these cases. If you didn't remove the membranes and try to stretch the iris, you are going to have a lot of trauma. Very important sign you are going to see that these particular hemorrhages that appearing at the edge of the pupil is a sign that you are removing the membrane attached to the edge of the pupil. Very important, don't stretch too much because the iris is fibrosed and you can have iridodialysis very easily. With the microforceps, you can remove also the adhesion. Take your time. This is not a normal cataract case. As meticulous, as neat surgeon, you are going to decrease the post-operative inflammation in these cases. Once you remove all the fibrous elements at the edge, which is very important to remove it, to decrease the incidence of inflammation post-operatively. Now you need to dilate the pupil in the proper size, because if you didn't dilate the pupil in the proper size, you are not going to do the proper size of the rhexis. In this case, I choose the iris hooks. Very important to do the rhexis central. Take your time, because these capsules are not the normal capsules in any cataract. It's full of inflammation, and the structure of the capsule is different. It can extend easily anytime. So after you finish it, you do the IA. Do you see? Do you hear me?
Yes, we can hear you.
Yeah. Okay. Okay. I think the video is stopping. But after I finish and putting the IOL in the bag, I found that and removing of the iris hooks, I found the iris is not well in size. So at this point, I choose to do pupilleplasty in these cases. So with the 4-through pupilleplasty, which is my good technique in these cases, very important, don't leave the eye like this, because you are going to have a glare post-operatively. So I take a stitch here in this side. Then I did the same in the other side. And after I finish, I reached the good size I wanted for the pupil. Washing the disc is very important in these cases. The second case I'm going to present is a case of Behçet disease. Which is totally different than any case, because in Behçet disease, usually the capsule is fibrosed, and you have a lot of adhesion between the iris and the anterior capsule. It's not an easy to remove this fibrous tissue in this Behçet disease. And you're going to see now even the structure of the capsule is totally fibrosed, in spite it is not a total cataract. You can see the red reflex. But removing the membrane, as I said, it's very important in these cases to have the proper size. Viscodissection in these cases decrease the post-operative inflammation, because it is less trauma to the iris. And with less trauma to the iris, it means less inflammation post-operatively. I'm trying to do the manual dilatation, but I failed. I didn't see that good size. So I used the Malyugan ring in these cases to help me to have the good size of the pupil. And you're going to see now, when I start the capsular rhexis after staining, it's a fibrosed anterior capsule, which is so difficult to have a good size rhexis easily. So I open it with the insulin needle first, with the capsular rhexis forceps, I tried to do a good size of the rhexis, but take care of at the every radial fold you are seeing, it's a site is the site for extension. So at every radial fold, stop, then stop the doing, then catch the rhexis again to have the proper size. I thought that the operation is finished like this, and it's a normal phaco. I usually phaco normal, but after I finish the complete taking all the nucleus, I found there is a complete sheet of opacification over the capsule. I know that YAG laser increases inflammation, so I try to polish the posterior capsule till you find a plane. Now I found a plane between the cells over the anterior of the posterior capsule. This is the plane. Polishing the posterior capsule more and more till you remove all the cells. Very important to remove as much as you can from the cells to clear the visual axis of the patient and to decrease the time to doing the YAG posterior capsulotomy. So take your time. The posterior capsule in these cases are very strong from inflammation. Don't be afraid. Remove the cells. You are going to make it easier, but take your time. Hydrate the cells more and more. As much you hydrate the cells, you can remove it easily after polishing the posterior capsule as much as you can to clear the visual axis for the patient. Then after you finish polishing of the posterior capsule, you are going to implant single piece hydrophobic inside the bag, then remove as usual the Malugin ring. And finally, the important message I have to say, uveitis is a wild card when it comes to cataract surgery, but attention to details, atraumatic surgery, and appropriate anti-inflammatory regimen can greatly increase the odds of success. Thank you so much. Thank you.
Excellent talk, Dr. Armia.
Thank you, Dr. Ahmed. And now we are going to have Dr. Ahmed completing the journey for cataract. Please, Dr. Ahmed Shama, Professor of Ophthalmology, Alexandria University, Egypt.
Can you see my presentation now?
No, can you share your presentation? Dr. Ahmed, do you open the presentation? Yes?
Yes.
Okay, and you can choose the green button from down to share the screen.
Can you see it now?
Not yet. دكتور أحمد.
دكتور أحمد، أنا كريم مع حضرتك.
كريم.
حضرتك الأول افتح بس الباوربوينت الأول.
تمام.
وبعد كده هنلاقي تحت فيه زرار أخضر كده تحت الصور بتاعت السبيكرز اسمه شير سكرين.
عملته. ماني في دول بقى.
Dr. Ashraf, you
Yes,
have so
Sengul.
many questions. Maybe while waiting for the presentation, you can reply some of
Yes.
them.
Okay, there is a question from the start. Say that the patient with Behçet, phaco-vitrectomy done. Patient has fluctuating IOP and inflammation. When to operate? This is between you and Ahmed Elkarmouty. Sengul.
Sorry.
Okay.
Okay, sorry.
Okay.
Can you see it now?
Yeah. Yes. Well.
Okay. Dr. Sengul, are you going to answer the question?
After you talk to Dr. Shama.
Okay, great. Thank you, everyone, for sharing with me this nice event. Thanks to Mondifarm and thanks to Dr. Ashraf Armia. I'm Professor Ahmed Shama, Alexandria University, and former Proctor Fellow at University of San Francisco. I worked with Dr. Bob Nozick at the Uveitis Clinic for 1 year, and I had the opportunity to share with him many of his cases. Actually, I'm going to tell you about the evidence-based story of cataract and uveitis in the last few years. I had the opportunity to present a poster at 2001 at the ASCRS comparing between the hydrophobic and hydrophilic IOLs, 20 eyes in each group between hydrophobic and hydrophilic IOLs in uveitic cases, and they did great both groups at that time. Actually, there are many weaknesses in the published data as regards uveitic cataract, and this is because it's a chronic condition, chronic disease, and it's an ongoing process. So if you do a follow-up like for 6 years, which is most of the papers didn't follow, this is still a short period, because I'm following now some of my patients for 18 years who did cataract, and they do well at the start, and after many years, these things change. They may develop cocoon membranes later on. They may develop many problems. That's why it's a chronic disease, and you can see a lot of problems after that. Also, there is a lot of affection of the posterior segment, and I'm sure that Dr. Sengul is going to share with us her experience in such conditions. Most of the papers have very short follow-up period. With multiplicity of the and heterogeneity of the diseases, we cannot say that they are all the same. So a case of Behçet's is not the same as a case of Fuchs. Also, there is a small number in most of the studies. Actually, most of the studies have a case series, and it's not a multi-center study or something like that. And most of the studies are retrospective, non-comparative studies. These are the weak points in the literature review. That's why this is a field of controversies. We have lots of controversies about uveitic cataract. The only thing that you have to be sure of, and non-controversial, is the good control of inflammation before surgery by all medications is a must. So you have to control the inflammation before you start to touch your patient. By all means, corticosteroids, immunosuppressives, every drug that can abort the inflammation is a mandatory drug before you touch your patient. One of the controversies is whether to put an IOL in young children, especially JIA, or not. Shall we put an IOL? And you will find in the literature a lot of controversy about this, to the extent that some papers are talking about this controversy. And actually, if you read the recent papers, you will find that they are going to put more and more of IOLs in such cases, and especially if they combine with posterior vitrectomy with a very small gauge vitrectomy, like 25 or 23 gauge vitrectomy. They do the posterior axis through the pars plana after implanting the IOL in the bag, and they claim good results. These are some papers that show that there is good results in children with long-term follow-up and IOL implantation. In this study, half of the cases were implanted primarily in the bag IOL implantation. And as you can see, it's a series of 58 eyes. 19 of the 58 eyes had JIA, 2 Behçet's, 2 VKH, and 1 Toxocara. So in the pediatric age group, if you summarize the literature, you shouldn't implant IOL in a child, especially in very young children. If you have hypotony, if there is rubeosis of the iris, cases of intermediate uveitis, and complicated other eye. If you put an IOL in the first eye and it was very complicated, you shouldn't put an IOL in the other eye. Dr. Armia touched the IOL and the design, and which IOL we should put, a hydrophobic, a hydrophilic. Most of the papers are talking about the advantage of the hydrophobic IOLs, and others are talking about the advantage of hydrophilic IOLs. However, this review of Ku at 2014 showed that there is no big difference between the IOLs. Actually, you can use any IOL. However, we don't prefer silicone IOLs because some of the patients will need vitrectomy later on. So we agree that the acrylic are better IOLs to put. Non-plate haptic IOL is like contraindicated or not preferred. The plate haptic IOLs are not preferred. So you have to put non-plate haptic because of the phimosis that can occur with the plate haptic. And Dr. Armia said that the square edge design is important to decrease the PCO, which can reach 40% of cases. And then the question, when to do, if I have a significant cataract, I can't see, you are telling your doctor, you can't see well, and I need to do surgery as soon as I can. And the doctor says we have to wait. How long should we wait? And the literature is saying that we have to wait. Most of the papers saying we have to wait like for 3 months. Some papers are saying that in Behçet's disease you have to wait like for 6 months. But this paper didn't find a difference between 1 month of a quiet eye, totally quiet eye, and 3 months. But the number of eyes that were operated after 1 month were 56 eyes only, while the eyes that were operated after 3 months of quiescence were 408. who should do the surgery? The anterior segment surgeon, or a combination of an anterior and posterior segment surgeons, or posterior segment surgeon can do the job nicely? And the answer is, if the patient is having a need for vitrectomy, like he is having a very turbid vitreous, he is having something to do with the posterior segment can do the whole job. You can combine both. You do the anterior part and the posterior segment do the posterior vitrectomy in some cases. This is important in cases of problems in the posterior segment that necessitate vitrectomy, and this occurs in tough cases. And it is preferred that they use the small gauge vitrectomy, along with posterior subtenon injection of steroids or injection of implants that deliver slow release corticosteroids. The postoperative problems we have to mention as cataract surgeons, that cystoid macular edema is very high on the list. Posterior synechiae, PCO is very high, fibrin reaction, and glaucoma. And my colleagues talked about the glaucoma. We have to tell you that not all cases are like each other. Like there are tough cases like JIA, Behçet's disease, VKH, and there are some nicer cases like Fuchs and cases of anaphylactoid cataract cases. Now we have to speak to our patients about the prognosis. Half of the glass is full and half of the glass is empty. We should talk about low visual expectations. This is because of the structural abnormalities. And the most dangerous thing is the hypotony. And I have faced a case of severe hypotony after implantation of IOL. Everything went fine. There is no severe inflammation, but the patient in the immediate postoperative period was +3. And after 1 year, she was +6. And after like 2 years, she was +9. She was developing more and more hypotony with cystoid macular edema and mushroom-shaped swelling of the optic nerve. And the vision was decreasing. And I didn't know what to do with this patient. Recurrence of inflammation, high rates of co-pathology in the posterior segment, especially in cases of Behçet's disease. The prognostic expectations, in cases of like Fuchs, we expect 20/40 vision in 92% of cases. And if you think about regular cataract, it is like 96%. So it's like any regular cataract. VKH is like 67, posterior uveitis 57%. Behçet's disease is much worse. Sympathetic ophthalmia is low in the list. Expect hypotony if there is failure to achieve quiescence of inflammation, and you have to do the surgery, especially in children who you are afraid of amblyopia in these eyes. If your intraocular pressure, your starting intraocular pressure is less than 7, expect hypotony. If you have seclusio pupillae with normal intraocular pressure, you have to think about postoperative hypotony. If there is choroidal thickening, and if you are lucky and found a cyclitic membrane, removal of this membrane may save you from this hypotony. Dr. Armia touched also the patient counseling and talking to the patients about the general risk of cataract surgery, to do implant or not. Sometimes we don't do the implant. patient will need reading glasses in most of the cases because we cannot put here multifocals. So he should prepare himself for a reading glass. The surgery is more time consuming, as you have seen with Dr. Armia. It's a lengthy operation than any other operation. The possibility of significant postoperative inflammation and the delayed visual recovery are important things to discuss with the patient. He may need another intervention, and he should know that. And the most common is the capsular opacification. And there is need for systemic medications and excellent follow-up to avoid later complications. Thank you very much.
Thank you, Dr. Ahmed, so much for your nice presentation. You have some questions, Dr. Ahmed. If a patient comes at stage of acute of active inflammation and a mature cataract, he said, the audience said, I don't know what is going on behind the cataract. What can I do to perform phaco earlier than full control of inflammation?
First, I have to differentiate between whether this is uveitic cataract or cataract due to uveitis. I mean, if this is inflammation due to the hypermaturity of the cataract itself, and this is an anaphylactoid reaction to the lens material, and this is the easiest cataract case in case of uveitis. If you remove the cataract, you will find your patient is very okay and no sequelae. But if the patient is well known to be a uveitic patient and he developed cataract, I have to stick to the rule. The eye should be quiet first and we touch the patient.
Okay. What is the preoperative regimen of drugs before surgery, cataract surgery?
Actually, if the patient is taking his medication for uveitis, I don't stop any of his medications that he is taking, the systemic medications. I start at least 1 week before surgery with the topical steroids before the operation. And there is a nice paper of Foster published many years ago telling us how to deal with these patients before surgery. I stick to what's written in this paper.
Thank you, Dr. Ahmed. A lot of questions to the full panel, but before Sengul starts, there is a question was on the panel say, maybe it can take you to your presentation. If you did in cases of Behçet disease, you did a phaco-vitrectomy and you have a fluctuating IOP inflammation, what can you do? Do you operate or you wait till the fluctuation stops? Sengul, do you hear me?
Okay. Can I share now?
Yeah. Okay. Do you hear my question?
Sorry. Yes, I could hear. I think you asked if the glaucoma. Okay. Please go ahead.
If you have a fluctuation on the IOP, do you operate phaco-vitrectomy or you wait?
Okay, I think this is a question for the glaucoma persons mostly, but I can say that if this is after phaco-vitrectomy, probably you have already cleared the vitreous and you don't have problem with the posterior segment. The main problem is the glaucoma, so I will refer it to my glaucoma specialist.
Okay, so we are going to answer it at the end. Okay, so we are going to have Sengul from Turkey. We are very pleased to have you with us to complete the journey. We start from the start, and you're going to have a very important issue, our posterior segment, which is the main important issue in any uveitic case. Please, Sengul.
Thank you, Ashraf. I would like to thank you first for organizing such a beautiful meeting, even if it is in webinar. I have lots of very good friends from Egypt, and you will be one of them. And I will talk about vitreoretinal surgery for complications of uveitis. We talked about the anterior segment mostly till now, but we know that the posterior segment is influenced by uveitis in many types of uveitis. We can see epiretinal membranes, macular holes, resistant cystoid macular edema, or tractional or rhegmatogenous retinal detachments, mostly caused by vasculitis or pars planitis, or vitreous hemorrhage, mostly, especially with Ehl's disease, and some vitreous opacities. All of them had to be removed with vitrectomy, you know. We also do diagnostic vitrectomy, but I will not talk about that, just for complications of uveitis. So I will give you some cases, I will show you some cases and discuss those cases. So this is the first one. This was a 30-year-old female coming with a sudden diminution of vision in the left eye, which was the only eye. The right eye had a sudden visual loss 6 years before, and it was operated elsewhere with vitrectomy and silicone oil, but the vision was lost and silicone oil was left in place. But there was no problem in the left eye then. Now, 6 years afterwards, she had headache and red eye and loss of vision in the left eye just 2 weeks ago. It started 2 weeks ago, and she also had tinnitus. And a topical and oral prednisolone has been started elsewhere before coming to us. And this was the right eye. You see the vision was just very weak perception of light, and PCIOL was there. And the retina, as you see here, there were very atrophic retina with pigmentary changes in the periphery and a macular hole and associated shallow retinal detachment. And the left eye, as you see here, was just counting fingers from 1 meter and has 3 to 4 positive cells in AC and vitreous, and with very, very typical, as you see, whitish peripheral necrotic retinal areas, which is very typical for acute retinal necrosis, as you can guess. And we can also see it in the fluorescein angiography in the peripheral necrotizing vasculitis, and you see the cells in the vitreous also in the OCT. So we ordered the test, and she was positive with herpes simplex and varicella zoster virus, and the others were negative, and then started the therapy. This was after just 2 days after we start systemic acyclovir therapy, and we started pulse rate 24 hours after the beginning of the acyclovir therapy. And as you see here, the peripheral exudates started to decrease, and 2 days after that, again, it was much better. But since this was the only eye, we injected intravitreal ganciclovir just to protect the optic nerve. We don't want it to be attacked. And I also consulted this patient with my uveitis colleague Murat, and we planned the treatment together. And this was after two days, and again a second intravitreal ganciclovir was injected, and you see all the exudates were cleared within 2 weeks period. And vision improved, and prednisolone was started orally together with, of course, the parenteral treatment, but we just followed her in outpatient clinic with oral valacyclovir after 2 weeks of intravenous treatment. And 10 days later, she came to us, and we planned a laser to prevent the retinal detachment in the peripheral necrotic areas. But in that visit, we have shown so many vitreous opacities and new membranes preventing laser. Although vision was much better, 0.2, We suggested a vitrectomy at this stage, but she refused vitrectomy since this was the only eye. She preferred to wait. And we warned her for the occurrence of retinal detachment. And 10 days later, she came us with this rhegmatogenous retinal detachment and hypotonia. Vision dropped to hand motions level, and retina was totally detached. So what we have to do is just a vitrectomy, vitreoretinal surgery at this stage. As you see here, retina was contracted with the epiretinal membranes all over, and the peripheral retina was totally atrophic, necrotic. And we have to be very careful during removing these membranes, because you can induce near retinal breaks easily. And there are many membranes everywhere, so we want to peel the ILM also to get rid of all the membranes over the macular areas. And of course, we have to put silicone oil. And this was just 1 week post-op. She started to count fingers, and retina was totally attached. And this was 6 months. Vision improved to 0.3. Silicone oil was still in then. And then we removed the silicone oil after that. We usually keep the silicone oil a bit longer than usual in these cases. And this was 2.5 years afterwards. And now visual acuity is 0.4. Silicone oil has already been removed. Although you see so many peripheral proliferation, retina stays attached. So, my take-home message for acute retinal necrosis, vitrectomy is better to be done prophylactically before retinal detachment during the increased vitreous inflammation stage at the healing period, because most of these eyes have retinal detachment after the early good response. So, my second case is a 8-year-old girl who had strabismus in the left eye for the last 2 years and a recent hyperemia in that eye, and vision was full in the right eye, but just counting fingers in the left eye. We have cells, 1 positive cells in AC and 2 to 3 positive cells in the vitreous of the left eye only. This is the right eye, totally normal, and this is the left eye. You see vitreous is a bit cloudy, and you have a retinal fold coming from optic nerve towards the inferior periphery, attaching to the lens, at the back of the lens. So when we look at the fovea, macula is also involved with the traction, and this is the fluorescein angiography. You see diffuse vasculitis and capillary leakage everywhere. And on the membranes were also vascular in the fold area. So my diagnosis was ocular toxocariasis, and we ordered Toxocara IgM IgG, and we started systemic albendazole for a week before the surgery. We planned a surgery for this, and then this was the surgery. So as you see here, the retinal fold was extending towards the anterior part, inferior and anterior part, and it was just behind the lens, but we could find a plane to separate it from the lens, because we always try to spare the lens during surgery. We don't want to do combined surgery, especially in children, especially if it is uveitis. So we could spare the lens, and we could clear those membranes, separate them from the lens, and the main aim is to cut the connection between the posterior and the anterior part, so that this fold doesn't become more contracted and worse. After we do this, as you will see here, I have also peeled the ILM to get rid of all the membranes, possibly over the macular area, and try to remove the posterior hyaloid if it is possible, as you can see here. And at the end, I have done some laser to the peripheral ischemic areas, and I just leave the eye in air. And this is 2 weeks post-op, and the vision improved a bit, and the vitreous was quite clear, and macula was much better. This is the fourth post-op month. Vision was better, and the vitreous was still clear and the fold was much better, of course. You don't have to get rid of all those membranes. You just relieve the traction as much as possible, but you have to be careful about not producing new iatrogenic retinal breaks. So that's one of the most important clues, I guess. So you have to be very conservative and careful. So ocular toxoplasmosis is one of the most common causes of retinal fall during the first decade. If it is a unilateral intermediate uveitis, you should think about this. And surgical indications are macular ectopia and tractional retinal detachment, as in this case, in addition to systemic therapy. This is my third case. This was a baby, actually. This was a premature baby, 32 weeks gestational age and 1,600 grams birth weight, but he already had a systemic toxoplasmosis diagnosis, and he had hydrocephaly, and he was having systemic antitoxoplasma treatment. And the right eye was ophthalmic with posterior synechia and cataract, and ultrasonography revealed both tractional and rhegmatogenous retinal detachment. I will show why it is, because the retina was very highly mobile, and the left eye was microphthalmic, just the reverse and almost stylistic. And this was the surgery for the right eye. I had to do lensectomy also because I couldn't see the posterior pole easily. I just did, of course, lensectomy. I cleared all the lens capsules. I didn't leave any of them. And as you see, retina was very mobile, and there's a triangular shaped retinal break here. And this is the ridge area, which is because of the ROP. The peripheral part was totally avascular. This was the ridge area. And I was trying to do some vitrectomy, but boom, that we have a new iatrogenic break here in the ridge area. So I have to get rid of all the membranes, especially around that retinal break area and also in the previous retinal break area. But first of all, I should get rid of the subretinal fluid, then stabilize the retina with perfluorocarbon, and then I should do membrane peeling as much as possible. I already have a retinal break here, so I have to do what I have to do. You see, I try to peel the membranes. So this is actually something like a nightmare for us, but I keep myself from abandoning the surgery many times, but I was able to do the membrane peeling and the posterior hyaloid separation, and I could reattach the retina, and I did laser around the retinal break areas. This is the optic nerve head area, this is the right eye, this is the macular area, this is the traction area, and this is the post-op appearance of the eye. This eye was microphthalmic eye, this is the ophthalmic eye. You see the pressure was still high, and we started brinzolamide, and he did well. This is the post-op appearance of the fundus, and he can see with this eye, he can react with this eye, but of course he cannot measure it, but he can follow the light with this eye. So I just left the eye with the gas, that's it, no silicone oil. And I just want to emphasize that inflammation may stimulate ROP progression in even bigger prematures, and toxoplasmosis may end up with tractional retinal detachment and also with rhegmatogenous retinal detachment, which needs surgical treatment. And this is my fourth case. She was a 7-year-old girl with sudden loss of vision in the right eye, and the vision was just hand motion in the right eye and 0.8 in the left eye, decimal. And anterior segment was unremarkable. We can see vitreous hemorrhage in the right eye, and ultrasonography revealed just vitreous opacities with minimal inferior peripheral tractional retinal detachment, very, very peripheral and minimal. And we can see two positive vitreous cells in the left eye. And the systemic workup with pediatric rheumatology was almost totally negative, except from HLA-B51. and all the others were negative. So this can be a Behçet's disease, for example, but there was nothing at the moment, but it can also be a pars planitis case, for example. So I acted this as pars planitis because I will show why it is so after surgery, actually. But before that, I did a fluorescein angiography. As you see here, we have very diffuse vasculitis, peripheral vascular leakage, and we started oral prednisolone and azathioprine for the first of all, and then vitrectomy with encircling band because there were some peripheral tractional retinal detachment already. And this was the other sides of the left eye. You see diffuse leakage in all the vessels. And after vitrectomy, what I have seen in the vitrectomy was the peripheral snow banking, which is very typical for pars planitis. And during examination under anesthesia, I have seen those things also in the left eye. And I thought this was pars planitis. And this is after the surgery. You see the fovea of the right eye was totally normal, which was covered with all the membranes during the surgery. And I did also laser photocoagulation to the inferior periphery and also intravitreal triamcinolone. And I also did a fluid air exchange. That was it, nothing else. And she did very well after this. Another case is a 65-year-old male patient with pars planitis, again, with secondary vasoproliferative tumor in the left eye. You see this was the left eye, but in the periphery, there was, in the very periphery, almost in ora serrata, you can see the mass. And this was the fluorescein angiography. You can see some peripheral vascular leakage. And to that vasoproliferative tumor, we did just cryo and posterior subtenon triamcinolone injection, triple cryo, and then it gives a good response to this, and the vasoproliferative tumor started to get smaller. So this is another complication of uveitis in posterior segment. This was a very peculiar case, actually. He was an 11 years old boy with 0.5 vision in the right eye and 2 meter counting fingers from 2 meters in the left eye. This was a sudden loss of vision in both eyes, as he says. Anterior chamber was almost totally quiet, but you see very severe vascular problems in the posterior segment. In the right eye, you see neovascularization on the disc and some vitreous hemorrhage, some preretinal hemorrhage, and so many exudates around the first tributary of the superior temporal vessels. And I could see something like aneurysm, very similar but not very typical in the center of these exudates. And in the left eye, the peripheral part was almost completely empty without any vessels. And there were so many new vessels, membranes, and some premacular and vitreous hemorrhage. This was the OCT. The central part was spared. That's why he could see 0.5 in this right eye. And in the left eye, you can see many membranes and hemorrhages all over. And this was fluorescein angiography. You see the neovascularization and peripheral avascular retina, very ischemic retina in the temporal periphery and all over, actually. In the right eye, this was the right eye, and this was the left eye, which was worse. You see the peripheral retina was almost totally avascular. This was the optic nerve head area, and these were all totally neovascularizations, neovascular membranes. So I decided to do vitrectomy in both eyes, and I did, of course, pre-op anti-VEGF, especially to the left eye. And the systemic workup was totally negative again, and vasculitis markers, thrombophilia panel, sifting test, rheumatology consultation, everything was negative. And no Behçet symptomatology, family history was also negative. So diagnosis was probably ear one. idiopathic retinal vasculitis, aneurysm, and neuroretinitis. Although I didn't see any apparent neuroretinitis because it was full of neovascularization and membranes, but probably the aneurysms were not so typical, but probably those were aneurysms. So I did vitrectomy to both eyes. I left some membrane in the most proliferated area to avoid from iatrogenic retinal break. This was the right eye. Vision improved to 0.9. I did lens-sparing vitrectomy without lensectomy, and the retinal macula was quiet. And this was the left eye. After vitrectomy, you see it was totally clear, no exudate, no edema, no recurrence, and it didn't need any additional immunosuppression. This was the third year after the surgery, which became 0.2 vision, and I just used air for the tamponade. So again, vitrectomy helped these eyes to get quiet. Another case, which is very interesting case to me, she was a 17-year-old young lady, and she was diagnosed as autoimmune retinopathy with one of my uveitis colleagues, very famous uveitis colleagues, Dr. Tutkun, and she had diagnosis of uveitis since 13 years old, and she had previous Ozurdex injections, the last one was 2 years before. It didn't give good response to it. And she had some systemic problems. The previous diagnoses were idiopathic juvenile arthritis or herpetic uveitis, many things. And methotrexate was tried, Valtrate, Humira, and no response. And when they started tocilizumab, then the systemic conditions was much better as they have in their history. And she had bilateral cataract surgery 6 months earlier before she came to me. And she has PCIOL in both eyes. So this was the fundus pictures of both eyes. You see it was hazy because of the membranes behind the lens also. And there were some membranes in the peripapillary area causing traction in the macular area also, as it is the case also in the left eye, which was a bit better, and they were causing traction also in the macular areas, as you can see in the OCTs. And what I did was just vitrectomy, membrane peeling, and intravitreal triamcinolone, and I left the eyes in the air, and this is the post-op 1 year appearances, as you can see. Although there was some peripapillary exudates still there, and some peripheral retinal RPE atrophies, she was much better with 0.2 and 0.3 vision, and the macular traction was much better. There were some exudates also in the papillary area, but she is getting some Ozurdex injections in both eyes when needed, but much less. These were the main cases, but I will give a very short pictures of some other cases like CMV retinitis associated epiretinal membrane in an HIV patient treated with vitrectomy and did very well. Another CMV retinitis related rhegmatogenous retinal detachment in a 12-year-old girl with non-Hodgkin lymphoma, and we did vitrectomy with silicone oil, and she did very well after silicone oil removal. Another case with endogenous candida endophthalmitis, which is kind of, uveitis, and it was cured with vitrectomy. If it doesn't respond to systemic therapy, we have to do vitrectomy in such eyes, and it gives quite good result with the vitrectomy. Another case with Behçet's disease, vasculitis associated macular hole case. As you see, there is a vasculitis area here, and the posterior hyaloid contraction caused macular hole formation, and we did just posterior hyaloid separation and ILM peeling, just routine things. This was like 6 years before or so, and also we have to do laser to the vein occlusion area, which was full of some neovascularizations. And that's it. Then you usually end up with closure of macular holes. These are usually atrophic retina. Because it's ischemic retina, you have usually atrophic macular holes. And also this can be secondary to cystoid macular edema because of uveitis. You see the vasculitis very well after the vitrectomy. And this is a sarcoidosis-related vasculitis-related rhegmatogenous retinal detachment, which was fixed with vitrectomy, silicone oil, or Eales disease. We usually have to do vitrectomy for recurrent vitreous hemorrhage. If it doesn't resolve spontaneously, we have to do laser, of course, to these eyes. So my take-home messages are, we have to do vitrectomy in uveitis. In some cases, it's helpful to remove the vitreous opacities, retinal membranes, and inflammatory debris, and to control the inflammation in some of the cases. And it's mandatory for tractional or rhegmatogenous retinal detachment treatment or macular hole treatment. Thank you all for listening to me to this late. It's almost midnight in Turkey, and hope to meet you again in person in Egypt.
Thank you so much, Sengul, for this great presentation. Really, you covered nearly all the posterior segments in uveitis. It's very wonderful. You have some questions. What about the TB workup?
Tuberculosis?
Yes.
Yeah, of course. We always exclude tuberculosis because it's the great mimicker, as you know, by doing quantiferon test. If it doesn't, if it is negative, then we continue with the steroid therapy or the other things. We have to exclude all the infectious disease. But I don't have any tuberculosis-related vitrectomy case, so that's why I didn't deal with that.
Okay. The other questions say, why was intravitreal cyclovir given 7 days after the presentation, or given it earlier may have prevented the RD for the first case?
Okay. Actually, the patient has given a good response to intravenous treatment already, but I just wanted to protect the optic nerve to become affected. I just want to support the treatment. Of course, we could do it from the beginning to use all the weapons that we have from the beginning, but it takes some time to get the drug from the first start, from the beginning. That was because of that, but we could prepare the drugs after like 7 days or so. But that was to protect the optic nerve, to give some more support to the last, the only eye. But I'm not sure that it will protect for retinal detachment. It will just control the infection. But we already have necrotic retina in the periphery, and you control the disease, but you can't control the necrotic retina, the traction over the necrotic retina. It's something mechanical, probably. So I don't think ganciclovir will add to protect the retinal detachment.
In the case you presented with Irvin, they are saying why you didn't put the differential diagnosis of Eales disease.
Why I didn't what? Sorry?
Put the differential diagnosis, consider the differential diagnosis of Eales disease.
Eales disease?
Yes.
Yes, of course. That's also, both of them are asymptomatic, idiopathic. So I preferred Irvin because we have so many exudates. It's not common for Eales disease to have so many exudates. They are around some areas which were like kind of aneurysm. That was not so typical, but still I thought because of those exudations, I thought it could be Irvin. Of course, I'm not so sure because it was not so typical. But in Eales disease, we are not so used to see so much exudates. That's why. Of course, it's in the differential diagnostic list.
In cases of fungal endophthalmitis, do you go for partial vitrectomy if the vitreous is clear?
Can you repeat it? Sorry.
Yeah, what's the indication of vitrectomy in cases of fungal endophthalmitis if the vitreous is clear?
Okay. If the vitreous is clear, I don't do any vitrectomy. But if I have vitreous opacities, which doesn't respond to systemic therapy, it's going worse and worse, then I do vitrectomy. If it is clear, I don't. But if I'm not sure about the diagnosis, of course, I can take just vitreous specimen for that. That's another thing. But for therapeutic approaches, no.
Okay, thank you, Sengul. And I have a question for Harry. I know you answered, but what is the role of aspiration from the anterior chamber to diagnose the type of uveitis?
The question again was about anterior chamber taps.
Yes, yes, because this is a common question for many.
I would love anterior chamber taps to be more useful than they really are. So we found that for the most part, when you do them, you're unable to amplify any viruses. Professor Chi in Singapore is really the person that's published the most on this, and different populations have different epidemiology around their different types of viral uveitis. But certainly in our practice in the UK, I've found that anterior chamber taps have been minimally helpful. I find it useful if you're not sure whether someone's got Fuchs or not, and you manage to demonstrate that there's a virus present, such as rubella, then that's great, because it kind of supports your diagnosis and gives you license to treat their anterior uveitis differently to everybody else. So that's quite nice. And generally speaking, if I'm doing a phaco on somebody who I wonder whether an anterior chamber tap would be helpful, I tend to do an anterior chamber tap at the beginning of the phaco because it's easy and it might contribute. But for the most part, I would say that they are never as helpful as you want them to be.
A question to Paul: how do you deal with hypotony post-surgical? Which is a very common complication.
Well, one of the first things, as we mentioned, is to do a UBM. And for UBM, often we'll look for the cause. Post-surgical hypotony can be caused by cyclodialysis cleft, which sometimes is hidden by PAS. We can also, on UBM, find, obviously, a small uveal effusion. They can have cyclitic membranes, which are more prevalent also. So often, if it's more anterior segment related, we'll try to do this ourselves. We'll start the patients on cycloplegia to try to stick the ciliary body back on. We'll think about using steroids, be they oral or topical steroids. And in some cases, we've also, our retina colleagues or ourselves have put in a CTR with little loops and kind of tied it to the sclera to try to stick the ciliary body back to the sclera or fill the eye with silicone oil. So no easy answer, but I think we have to find the reason for it. More common in patients, obviously, with chronic uveitis, but UBM is a very helpful tool in these cases.
Sengul.
Okay, I would like to comment on this issue. I have already written a response to the one of the questions from the audience also. Hypotony is a very common complication, unfortunately, especially for the pars planitis or our other uveitis, especially affecting the posterior pole. What I do is, I completely agree with Paul that I should do first the UBM to see if it is caused by a membrane in the pars plana area or a peripheral retina coming from peripheral retina, or if it is a cyclodialysis cleft or things like that, or if it may be because of the atrophy of the iris, ciliary body. So first we should be clear about this issue. After that, if it is caused by membranes, peripheral membranes, I would try to do a vitrectomy together with, if it is together with cataract, I would do combined surgery with vitrectomy for these cases, and I try to remove those membranes as much as possible. It's not an easy thing, and it's usually not possible to completely get rid of those membranes, but we should give some chance to clear those membranes. And if it doesn't go away totally, I sometimes put an encircling band, which is an anterior encircling band just behind the insertion of the rectus muscles to support both those membranes causing traction to the ciliary body, and also that will also support the ciliary body to protect, to support the cyclodialysis clefts or things like that. So if it is very hypotonous, I can put silicone oil, but I try to avoid from that, because when you put silicone oil, if it's still hypotonous, it will come into the anterior chamber and it will cause, you know, the band keratopathy, corneal opacification, and all those things. So the first thing is to get rid of the hypotony first by means of the etiology, dealing with the etiology. And I also use steroids a lot, intravitreal or posterior subtenon steroids.
And Sengul, do you ever use endoscopy also because sometimes endoscopic vitreal surgery, you get a better idea of the anterior vitreous?
Yes. Actually, I don't have any endoscope. It's very artistic usually. It usually gives quite nice views. But if you can see, if you don't have any lens problem or pupillary problem, when you indent it, you can easily do the surgery.
Dr. Shama, do you routinely inject steroid posterior subtenon or intravitreal at the end of the cataract surgery in Uveitis?
Yes, I use it as a routine in all cases of uveitic cataract. And you have to do this especially in children. If you are doing a child, it's a routine thing.
For how long you are going to use the cyclo ventilator, cyclo drops post-operatively in these cases?
According to the inflammation you are seeing. If you are seeing a regular inflammation or minimal inflammation, you shouldn't use it for a long period. If you are seeing a lot of inflammation, and this is actually in the tough cases I described in my presentation, I usually prolong the use of short-acting mydriatics, and I don't prefer the atropine or long-acting.
Dr. Ahmed Armouti, if you are going to choose between trabeculectomy, mitomycin, or deep sclerectomy in case of uveitis, what you are going to choose?
Okay, what kind of uveitis? So it's always the question to be completed with the uveitic glaucoma is which kind of uveitis. If it is VKH, GIA, GIA, VKH, and Behçet, yes, you can try the deep sclerectomy, but you have to be prepared that you may need another procedure along the way, not trabeculectomy in these cases. But if you have anterior recurrent idiopathic uveitis or infectious uveitis, you can try for the anterior recurrent idiopathic uveitis, you can try the trabeculectomy. You may have good results for that. But for the infectious, probably I will go for a shunt. So it's always the question, what kind of uveitis associated or causing the uveitic glaucoma?
Thank you, Ahmed. Harry, there is a question direct to you. He said, hi, Dr. Harry, what is your experience with the HIV and the DMARDS? He's working in South Africa with the high incidence of HIV. So the significant proportion of our patients are infected. Do you use the DMARDS in HIV positive patients? What do you?
So, I mean, the person who asked the question definitely has more experience of patients who have bad HIV than I do at the moment. We're lucky where I work, and it's unusual for me to see patients who have poorly controlled HIV. I have a number of patients who have well-controlled HIV who effectively have normal immune systems because they're on their correct HIV medications, and their lymphocytes are in the right place, their CD4 counts are in the right place, and so I treat them as I would anybody else. If you have a patient who's unable to afford medication or who's sort of developed an AIDS-defining illness, I feel like I'm probably not the best person to actually offer advice on this, because it was the generation before me that was managing these patients. Perhaps other people on the panel might be better at offering advice on that. But certainly in my personal experience, I only manage patients who've got relatively normal immune systems.
Thank you. Well, there is a question. Do you prefer intravitreal over intravitreal as first line for ARN? Intravenous or intravitreal as a first line for ARN?
For me, Ashraf?
Yes.
Okay.
Yes. For you, yes.
First of all, I usually prefer to do intravenous, but I support the intravenous treatment with intravitreal ganciclovir injections. But first of all, I start with intravenous, yes, systemic.
For Paul and Ahmed Elkarmouty, in case of uveitis, when you have you did the operation with a valve and you have resistant high intraocular pressure with a good vision, still good vision, what the second choice you are going to use?
Okay, Paul, you want to start or shall I go ahead?
Go ahead, Ahmed.
Okay, if it is uveitic glaucoma and it's still quiet and failed Ahmed valve, I will go for a Barville tube with 350 mitomycin in another quadrant. If the uveitis are due to anterior not recurrent uveitis or infectious, if it is VKH, GI, I can still do a diode in between. But if it is VKH, GIA, I will go straight for the Barville tube without the diode.
Yeah, I would agree with Ahmed. I mean, when our tubes fail, usually we use Ahmed tubes, when we want to avoid hypotony. The Barville has the benefit of achieving lower intraocular pressures, however, with a higher risk of hypotony. With failure, we've actually published this year in Journal of Glaucoma revising tube shunts. We actually go back and remove the capsule which is formed over the tube shunt. So I'm a personally, if someone has a big piece of plastic, I try not to put a second big piece of plastic in the eye, although definitely it's an option as a cilioablation. But I'll usually try to remove the capsule, put an Ologen implant with mitomycin. Sometimes the tubes also fail because of vitreous or some other debris which is stuck within or from the outside, and we have to pull that out surgically. And another option is actually replacing your Ahmed tube with a Barville implant and getting that extra space. So a combination of those can be used.
Dr. Ahmed Shama, if you're injecting an Ozurdex and second day you are going to find a pellet in the anterior chamber, what you are going to do? Because this is common in case of uveitis, usually has subluxation or weak zonule. What you are going to do?
I'm not sure. I haven't faced something like this. Tell me, Ashraf, what you're going to do.
For sure, I'm going to remove it, but during opening the eye second day, have an increased risk of more inflammation. Definitely, but
I mean, you finished your case nicely and everything was all right. What is the cause of zonular dehiscence, or what's the cause of
This case, it didn't happen to me. It did to some of my colleagues, and he said he injected the Ozurdex, and second day he found it in the anterior chamber, in the lower part of the anterior chamber. Okay, Harry, the last question: when you are going to give the green light for any cataract or glaucoma surgeon to say that your patient is okay, go for surgery?
So I'm going to say what Ahmed has been saying about all of the glaucoma surgery. It depends on the uveitis. So in our practice, we say 3 months of inactivity. Sometimes it's not possible. Sometimes in order to get 3 months of inactivity, you've got to keep somebody on unreasonable doses of systemic steroid. You've put in your intravitreal steroids, it's not done anything. I would try everything you can possibly do to get the eye quiet before surgery, be that intravitreal or systemic therapy. We tend to do, even once we've got quiescence, I'll generally, if it's a patient with posterior uveitis or someone who's previously had macular edema, I'll still put them on 0.5 milligram per kilogram of prednisolone the week before surgery. And I often give people pre-op Ozidexes 2 weeks beforehand. So I have a very low threshold for marinating people in steroids essentially prior to surgery. If you can't get someone quiet before surgery and they need to have surgery, if they've got iris bombay and they've got an eye full of cells, you're going to have to proceed. But I would get as much steroid into them as possible. I'd have a low threshold for giving them intravenous methylprednisolone on the table. One of the questions earlier on was whether we put TPA in patients to prevent the fibrinous uveitis sticking down again afterwards. I do that a lot in the JIA uveitis patients who I find often do stick down, have a really horrible post-operative period. So I have a low threshold, bring people back at day 2 and giving them intracameral TPA. And I find that sometimes helpful. And you just need to watch people very carefully post-operatively if they're not quiet pre-operatively.
At the end, thank you so much for everyone. Thanks for Dr. Ahmed Shama, Sengul, Ahmed Elkarmouty, Paul, Harry for being with us. Thank you for everyone. Thanks for Mondi Pharma. And it was my pleasure to have all with you. Thank you so much. See you soon, in real life, not virtual, very soon. Thank you so much. Thank you.
Thank you very much. Thanks, everyone.
Thank you for inviting us. Bye.
Thanks a lot. Bye-bye.
Thank you.
Thank you.
Bye.